Happy Friday, everyone, and welcome to this week's Power Hour. Today, we're going to be talking about team-based care and the interprofessional team. And I know that you're going to get so much out of the group of guests that we have with us today in our Zoom studio. So we're very excited about today. As always, as a reminder, the Power Hour came about as an effort to really focus on what we can do as the pandemic hit and closed down the state. And what we can do is really to focus on conversation about everything and collaboration, but maybe above all on community. And that's what our aim is with these sessions that we do at this point every other week, where we talk about a topic and invite distinguished guests such as the group that we have with us today. As always, my eminent moderator here is Franklin Walker, who I think has found a second career with this. And with me today, I also have Danielle Snyder, and my name is Christina Natterdog, and Power Hour is offered to you by the North Carolina Medical Society Foundation. This is going to be a recorded session and will be available for you sometime mid next week on the Leadership Development landing page at the Medical Society website. Without any further ado, I'm going to hand it over to Franklin. Thank you so much to all of those who are joining us today, and I look forward to the session.
Super. Thank you, Tina, and welcome to my guests. And what I'd like to do first is come to each one of my guests and allow you to introduce yourselves and tell us a little bit about your workplace and your positions there. So, Dr. Daniel Mahaffey, would you please do us the honors of kicking us off?
Sure. Welcome. Nice to virtually meet all of you. I'm Danielle. I am a family medicine doc. I did a sports medicine fellowship years ago and was in private practice for years. And currently I'm in the position of chief physician executive at Appalachian Regional Healthcare System. In my role, I currently work directly with all of our employed providers. I work with quality with our health system, population health, and our medical staff. I've been with ARHS for almost 5 years.
Super. Thank you so much.
And I am blessed with working with the North Carolina Medical Society as one of their board members and have been for the last couple of years.
Well, that's
Let me add that there too to give you guys a plug.
We appreciate that plug. Thank you so much. Michael Lischke, please, sir.
Hey, hello, everybody. My name is Michael Lischke, and I am coming to you from my home office, but paycheck comes from Wake Forest School of Medicine, where I serve a few different roles. I'm on faculty in family and community medicine on the non-clinical community medicine side of the fence, if you will. The associate dean for continuing medical education, and probably the thing I spend my most time on is I head up the director of the Northwest Area Health Education Center, one of the 9 regional AHECs in the state. And am very proud to be partnering with Christina and group with the Future Clinical Leaders College undergoing right now. So it's great to be here. Thanks for having me.
Well, welcome. Well, both of you guys are wearing a lot of hats for your various organizations, which is awesome. So since today's talk, our discussion is going to be about team-based care, I thought I'd start out by reading one of the multiple definitions I found about team-based care. The National Academy of Medicine defines team-based care as the provision of health services to individuals, families, and or communities by at least 2 healthcare providers who work collaboratively with patients and their caregivers to the extent preferred by each patient to accomplish shared goals within and across settings to achieve coordinated, high-quality care. So there's a lot to unpack there, right? So I guess I want to start out by just asking you guys, what do you think some of the benefits of team-based care, both for the patient, your team, and your organization? And Michael, since I'm looking at you, I'll start with you, please, sir.
I guess my lens would be from the non-clinical side. So I'll take it from the patient side of the fence. And the example that I'll give is just like all of us have examples in our families. And my family, our big issue seems to be various cancers. So my father had prostate cancer. We moved him, quite frankly, from Atlanta, Georgia to Winston-Salem to get his treatment from the Comprehensive Cancer Center at Wake Forest. And they did everything they could possibly do. And that was 15 years ago. So this team-based care that we're talking about really wasn't part of the scheme, if you will. It wasn't the norm. So we would literally go from his primary care doc's office to the treatment place, across the town to another building or another place for his cancer physician follow-up appointment, and very disjointed. And again, kids that he have had part of raising are in the system. So we struggled, even being in part of the system with him 15, 20 years ago, on how to make all that work, right? So fast forward it to 3 years ago, my mother, who still lives in the house right around the corner from us here outside of Winston-Salem, small cell lung cancer. And we thought, okay, well, we're going to have to figure out how we're going to juggle this and be on top of this. Same cancer center, same kind of workup, if you will, but all in one location. True team-based care. We arrived at the cancer center at 7 o'clock every morning for various treatments, and we didn't have to leave until we were ready to leave to go home. And so it became totally so focused on the patient and supporting the patient and the family that we often talk about that as a family, because it is an absolute night and day difference of our experience. So I would kind of throw it from that lens, that it is from a patient family lens, it is the most amazing thing, because you have to go through that stuff. The amount of support you get by not having to haul and cart people from one building to the next building to across town to 4 miles away or whatever, has been a powerful thing. So that's how I've kind of lens it, if you will, from a non-clinical caregiver side.
Well, and the fact that you were able to make it personal makes it that much more powerful. So thank you for sharing that with us. Danielle, can you speak to that same question and perhaps address it, of course, as a clinician and in your role in your organization, please?
Yeah, absolutely. I love where we started with this, because it's, at the end of the day, it's all about the patient. I think traditionally, if you look at medicine years past, as a provider and as a physician, we've set up a lot of care traditionally in historical perspective based on what's easier for the provider. And that shift of focusing on the patient and what the patient needs and bringing that to the patient in one situation and making it easier is something that he just hit on. From a physician perspective, however, I think team-based care has so many benefits. Number one, the complexity of just practicing medicine nowadays, it's gotten away from actually taking care of the medical needs of the patient into paperwork and documentation and coding and so much, that if all of that falls to the provider to do at the end of the day. I think there was a study once done that I like to quote that said that for primary care, if a physician, and this was 10 years ago, if a physician did everything in a normal scope of family medicine in one given day that was required to take care of the patients that were on their schedule today, it was something like 27 hours worth of work. So expectation is just not reasonable to have the provider be responsible for all of that. And so plus the fact that they may not be the right person, or they may not be the expert in that. If we're talking about nutrition, if we're talking about pharmacy and medications, if we're talking about other things, you may be able to bring somebody in the room, if I'm seeing a patient that knows a heck of a lot more about those elements than I do. So if you pair me up with team members that bring in different levels of expertise, then the patient is only benefiting from that. And it's each of us can work to the highest top of our license within any given area. The patient always wins, and we're distributing the work in a way that makes expectations reasonable. And from a primary care perspective, I can't really speak to specialty, but from a primary care perspective, it really brings a provider back to being able to focus on the things that have driven them and the passions that they have of why they went into medicine. So when I practice full time, I definitely practiced in a team-based fashion, and I'm not practicing now. We were talking about that a little bit before this call started, but if I were to go back into practice, I wouldn't do it any other way, whether that's scribes, whether that's RNs, whether that is PharmDs, who are proactively screening the charts and helping with patient care. It definitely gives better patient experience, to what Michael was talking about, and it definitely gives better quality of care. And and I think it spreads the work out, because healthcare has just gotten so complex, and the demands on the provider are so much.
Right. Okay. Well, thank you for both of those answers. Next question to both of you. And Danielle, you're right there, so I'll let you have this one first. What are some of the challenges and/or barriers that you guys have gone through at your system in implementing team-based care? And perhaps you can talk about the challenges and then how you've overcome them.
Okay, that's a good question. I think the biggest barrier that I come to with, even within a healthcare system, is if you have disparate systems that you're working out of. If we have different ways of communicating about that patient care, and we can't all have visibility into that. So even within our system, we have 2 hospitals and a employed provider group, and we haven't always had everybody on the same electronic health record. So if we're in different systems and we're not having that transparent communication, it makes it much harder for us to deliver. I think the obvious fix for that is to get on integrated systems where everybody has access. And the same thing with community. I know there are community interfaces now that are happening between organizations that support housing and food insecurity and different things. It's hard to go across different entities, let alone within the same entity, if you can't share that information about the patient care in a safe, confidential, and meaningful way. So I think that's one of the biggest challenges, honestly, right now, is disparate systems.
Right. Michael, I want to come back to you with that same question, but a little bit of a derivative, if you will, because you're wearing a multitude of hats, as we spoke about earlier, with school of medicine at Wake Forest Baptist, but particularly with AHEC, because AHEC, of course, is across the state. And the Medical Society and our foundation have done a lot of work with AHEC over the years, not just with CME, but with other programs. And we found them to be a very committed partner, if you will, to doing this great work. So can you tell me a little bit about school of medicine, but particularly about AHEC, please?
Yeah, certainly. I'll start with the AHEC piece, because that's what I think I know best on this in this realm. So at the end of the day, the North Carolina AHEC system is about recruiting, retaining, and training, right? I mean, I probably got those terms out of order, but those are the 3 magic things. So in this space, we call it interprofessional continuing education, right? And in this space, it's the big challenge is that to really do that and to do it well, it requires a level of time and energy from lots of different people who otherwise wouldn't have been involved. So conventional professional development, if you will, CME, nursing education, whatever it is, has always been very siloed, because that's the way the systems were built, to be siloed very intentionally. So to break down those silos a little bit and get people into the conversation, so that there's the CME CPD world, it's called Interprofessional Continuing Professional Development. It's 2 or more disciplines, and I have to always look, learning with, from, and about each other. So translate that to probably the most significant amount of education that happens at any medical school, any hospital system these days, is safety huddles, right? Those are very huge things they're doing great work. And then various grand rounds, disciplined grand rounds, right? Grand rounds have always been very, very physician focused. But when you look at who's really showing up to the grand rounds, the physicians are certainly there, but there's everybody else is coming too. And so to get that kind of cooperation and willingness to invite all of those different roles and responsibilities into it, it's a big task because it takes a lot of energy to lift that up. So that's kind of how I would respond to that question regarding, IPCE. And I think what Dr. Mahaffey was saying, the NC Cares 360 has become a huge, huge thing. And I'm a public health guy. I'm a traditional educated public health kind of guy. And what I find fascinating, the things we're talking about now in the NC Cares 360 realm, that's public health. We're calling it something different now. We're calling it population health, health of the public, health of the community. But that's public health at its core. And that we have known for many, 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 many decades that clean water and safe living and access to food and transportation and healthy environment, all of that is huge for the health of the public. And what's really super cool is I see all of that coming together. Different terms, different groups are calling it various things, but I think we're really, really onto something. And hats off to everybody who's been involved in this NC Cares 360 program, because I think that is worth its weight in absolute platinum right now for us as a state.
I agree. We use NC Care 360 for one of our opioid programs at the Medical Society. So we've been able to be end users of it. So it's been really a cool thing. I'm going to stick with you just for a second, Michael, because you talked a little bit about social determinants, as far as I'm concerned, about the public health factor, and you're clearly a proponent of that.
Yeah.
Have you guys started to then incorporate the social determinants of health within your team-based care systems and training folks on those? And then you're having, I guess, to expand out your team and beyond what's been the traditional clinician, maybe to community health workers or other, folks. Can you talk a little bit about that?
Yeah, I think there's a lot of work going on in this space from a lot of different really great groups of people across the state. The ones that I'm most familiar with, and probably the earliest ones, the Faith Health Group at Wake Forest Baptist, supporters of health, community folks who are maybe employed already within our system. We've done some projects with them where we've actually helped train people on how to address and how to help people get through, what was their statement? Care through the right door at the right time and not alone. If you really think about that, isn't that what everybody wants? Care at the right time, not when it's crisis, emergency room is your only option. Never alone. Nobody wants to go through anything alone, in the right kind of care at the right time. So that would be one way. The other build arounds, so social determinants of health, again, some could be critical of that and say, okay, well, that's the new sexy terminology for this public health stuff. And what we're doing, and we've been on this for about 2 years now, and it's really picking up steam. You can have a very well put together interprofessional continuing education activity focused on social determinants of health. People are doing it all over the country, multiple day conferences. You could probably have a slew of them. We've started, and it was about 1.5 years ago, we started this, is working with the people who are already organizing their grand rounds, whether that's Dr. Strowd, who I see on the screen, whether it's one of his grand rounds activities, and say, you know what, how can we help you weave at least one social determinants of health formal objective into what you're planning? What do you need to do that? So we provide resources. We say, hey, take a look at this. And for the most part, what we're finding, even where we thought we were going to get pushback, people are all in on this. So our logic is that I don't know of any medical issue, or I should say it's probably a very rare one, would probably be the better way for me to say that that you cannot appropriately weave into the conversation, social determinants of health, cultural competency, or healthcare disparities, because they're everywhere if you really look at it. So that's kind of what I would suggest as some things that I know about, that we're involved in, that I'm really proud of, because it really, in a supportive way, helps people shift what they were going to spend energy on anyhow, but doing it in a way that it becomes part of the conversation. And then on the clinical side, there's all kinds of screening tools now being added. At our downtown health plaza, I know for a fact they're doing a food insecurity screening tool. And, let's face it, if you're talking to adults, adults like to lie to each other. Oh, I'm good. Everything's fine. I've got food in the house, But if you ask a child, did you go to bed hungry over this last week? That child's going to tell you the truth. And so when that does happen at the downtown health plaza, the family walks out with 2 bags of groceries. So it's a grant funded thing. It's working through Second Harvest Food Bank. I mean, it's this multi-leveled organization thing that they follow up on. So it's those kind of things that really, it required a whole lot of trust between people and organizations that might not have been there in the past, and a whole lot of heavy lifting together. But I think that's the stuff that's making a big difference.
Super. Thank you. Okay. I want to introduce our third member of our panel today, who was probably taking care of patients, Dr. Roy Stroud. Good afternoon, Roy. How are you? Welcome to our discussion about team-based care. So I want to give you the opportunity to tell us about your position at your entity, and then would you provide your take on the benefits of team-based care from a patient, team, and organization perspective? Our other 2 panelists have already answered for their organizations. Thank you, sir.
Thanks so much for having me. I was racing back from clinic. I knew it was going to be tough. We have a busy clinic yesterday because we were closed, or a busy clinic today because we were closed yesterday. So sorry to be late. I'm a neurologist and neuro-oncologist at Wake Forest, and also work with our medical school here as one of our assistant deans of undergraduate medical education, and then have the great fortune of working with the North Carolina Medical Society, and many of you on the call, with some of the student leadership efforts that the Medical Society is doing. And I say that because that's really been my path to team-based care. I've drank the Kool-Aid. I mean, this stuff is where it is and what we should be doing. And for me, that all really came out of the clinic. In the cancer center, it is inherently team-based care. That's how we treat patients. And whether it be at a tumor board, sitting down, actually now we don't sit down. We're Zooming, with one another, with radiation oncologists and neurosurgeons and radiologists and neuromedical oncologists to treat patients, or whether that be looking at the social drivers that are contributing to outcomes for our cancer patients, or understanding the psychosocial impact of cancer. I mean, that's an integral part of my clinical practice. And for me, I haven't been at this for eons. And so as I entered into the cancer world about 7 years ago out of fellowship, I just took for granted the integral nature of team-based care for my patients, because it's just a part of the way the cancer center is set up. And when you think about what is needed for team-based care, I think it is a helpful model. We're all together. There's not departmental areas where people work. It is really built around the patient. The patient comes in, and all of those providers from all of those disciplines and backgrounds are there in the same space, a communal space that's around patients. And to me, that's a really rewarding a place to provide care. And I see the impact of patients every day. As an educator, because that's the other role that I have, many medical schools recognize the importance of this, and Wake Forest is certainly one of those. And probably about a decade ago, began to invest in incorporating team-based care in its curriculum and education. And I think that's really, really important. And our curriculum here, the way we look at that is really first understanding roles. What are the roles of the different providers around the patient? and making sure that the medical students understand what the PA students, what the pharmacy students and the nurses and others and the therapists and things are really doing around the table, and understanding how to communicate effectively, how to provide team-based care, and then the impact on outcomes. And we have a number of programs that are set up at the student level to teach those things so that early on in the careers of future professionals, they're understanding what everyone's doing, knowing how to communicate and seeing the benefit of outcomes, so that they're really the ones driving the call to team-based care when they get into residency, or when they're out there in pharmacy residency or in practice, having seen that in training. And that's been something that the school here, as well as many, have been increasingly investing in. And I think that's really, really important. A lot of this can be a top-down approach to incorporating and really embracing team-based care, but we have really seen the benefit of some bottom-ups, grassroots sort of efforts around that. And then the last thing I'll say is how are we, what are we doing at an institution or really even statewide level to address that? And I'm passionate about students, as you can tell. But a few years ago, we set up, as many on this call know, a statewide leadership program for students that is deeply interprofessional. And this is so cool. I got to brag about the program a little bit, but we sat down a couple of weeks ago with these students and had on the same call medical students, MD, DO, PA students, nurses, CRNA, DNP, occupational therapists, dentists, any professional you can think of around the table, and everyone benefited. And the MD students benefited from understanding what the training is for other professionals and how they think about how they think about patients and those sorts of things. And I think that's really, really important in this conversation, is the ability to engage with other healthcare professionals really benefits each individual provider in a way that they wouldn't have otherwise benefited.
Right. Well, thank you for that comprehensive answer, because you knocked out about 3 of my questions there. So that was beautiful, right on time. Danielle, I want to come back to you and talk about one of the benefits to the organization. In my research for this talk today, I was looking at the Journal of Interprofessional Education and Practice, and they talk about hot spotting, of course. And then at the back of this journal article, they had a chart and talked about chronic respiratory failure, cerebral palsy, diabetes, all these things. And then the total cost savings were amazing based on the hot spotting and then instituting team-based care. And everybody's bobbing their heads up and down. So I'm hopeful that you can tell us a little bit about how that's going with your institution.
Yeah, I think whatever you call it, if you look at transformation of patient-based care, if you call it population health, or if you look at bringing everybody together and treating our patients from a team-based care perspective, you can improve quality and drive down costs. One way and a good example of doing this that I have done in previous organizations and that we're doing here at ARHS is incorporating pharmacy into care proactively, not based on a referral from a primary care perspective. So like if they're on a high-risk medicine, identifying through your electronic health record who that panel of patients are that are taking that medication, and then having our pharmacy team keeping an eye on any issues that could be either quality or patient safety issues, and reaching out to those patients before those things happen. Those are meaningful. They're better care. They're preventing bad outcomes. They're improving quality, and they're preventing that outcome that was going to have downstream cost to the system that was avoidable. So there are so many inherent positives. Back to listening to I think oncology is an area or specialty that we have done well with team-based care in the past, just it's developed there. But in other areas of medicine, we haven't done such a good job with this. So I don't think we've done this in primary care as well as we have done, let's say, in oncology. We aren't getting the navigators involved and the nurses involved, and letting them work to the top of the license. We're not getting the pharmacists involved and proactively screening the charts and reaching out and working with the providers and notifying the providers if they see something that could potentially be a problem. And we're starting to do those things now, and have been really over the last decade. It's been more and more common, and I think it really has been shown across the board to be better for our patients, safer, higher quality of care, because we're looking at things in a proactive way and preventing the bad outcomes from coming. And we're bringing a collective group together that brings in different experiences. The last comment I'll make about this is, I think if you look across the world and you look at other nations, and this kind of brings in social determinants, it brings in different transformative care models, it brings in team-based care. If you look at nations that look at having healthcare expenditures in the areas of social determinants, or in the areas of not the I'm the doctor and I'm writing you a prescription or I'm doing a procedure, but what are the other things you need for your health that are just as important, right? If you look at nations that do that well, their cost of care is lower, and their quality is higher than what you see here in the United States. So we need to balance it out. We need what I do as a physician is important, in if I'm prescribing or I'm doing a procedure, but that is a small part of what our patients need. And we need to bring those individuals who know what they need outside of what I do, and my scope is my job, and bring them collectively so they can enhance what I'm doing in order to really get to the point where we're improving our quality and lowering our cost.
Sure. A quick follow-up. You mentioned the integration of pharmacists into your team-based care.
Mm-hmm.
We do a lot of work from the Medical Societies Foundation's Project OBOT with independent pharmacies across the state, not the big box guys. I'm wondering, since your healthcare system is kind of up in the Western North Carolina in a rural setting, do you involve the independent pharmacists in part of your team-based care? How do you, and if you do, how do you include them in that?
We collaborate with our independent pharmacies here, in the community for different things. They're not actually the ones that are doing, they're not who is in partnership with the pharmacy program that I discussed.
Right.
But some ways, we're working hand in hand with a local pharmacy right now in vaccine administration and COVID vaccine administration. I mean, they're we're working with Samaritan's Purse. We're working with Boone Drug Pharmacy up here. We're working with our organization, Health Department, and the FQHC, all coming together to be able to put a volunteer program together to distribute our vaccines. And we've done have been able to do that very effectively and successfully. Another program that we were working on with the local pharmacy here was the dispensing the pharmacy medications at discharge before a patient leaves. So if they're discharged from our hospital, they go home with their medicines in hand rather than having to go to the pharmacy. That's another project that we were working on in partnership with them. So those are two examples of how we work. And in a small community, sometimes Boone feels like a larger than we are, but we're really a rural community.
Mm-hmm.
We work really, really closely together across all organizations in our community to help deliver the care and fulfill the mission of our organization.
Super, thank you. Danielle, I think you may have a question in the chat. Would you like to pose it to our guests?
We do, yes. A question from the chat is, what are the team dynamics in each of your experiences?
Dr. Strowd, would you like to take that?
Sure, I'm happy to start, because as we've had this conversation, I had this great story come to mind. And there is a point to telling this story, so I'm going to kind of go through it with you. We run this DEA. Again, I'm passionate about students, do a lot with education, so it'll start with students, but I think it'll be relevant for all. So we run this DEAX waiver training simulation for our fourth year students right before they're about to go become interns. And it is a simulation. It's an interprofessional simulation. So the medical students and the PA students and the pharmacy students and our nurses and nursing trainees are there. And we throw them into a room with a patient who is having some acute life-threatening event, and that may be overdose. And in many of our simulations, it's overdose, to get back to the DEX waiver training. And we did this a couple of years ago, and they sort of walk into a room, and here this patient is, a standardized patient. And we had this one group going through it, and they had gotten about a minute or two in, they're figuring out what's going on. The patient needs oxygen, and the medical student walks over to the wall, to grab the nasal cannula, and he's winding himself up, trying to put the nasal cannula on. And about, 15 seconds goes by, and he's completely wrapped up in this nasal cannula. It's like a Saturday morning cartoon as you're watching this, and then he can't get out. He doesn't know how to get out of the bed, and now everyone's treating him and not the patient, and is, just this, fascinating event. And we debriefed after that and said, what are you doing going over and getting the nasal cannula? You got no idea what you're doing. And honestly, this is not only not your role, but this is not what you're good at and not what you should be doing. And it's really detracting from the team. And that story has stuck with me because it's just a great story, first of all. But it also is a reminder of how many times in our day-to-day jobs we step on other people's toes, other professions' toes, and become completely inefficient. And the system is just breaking down. And I think the story we just heard is a good example of this, about how, we talk about practicing to the level of the license. It really makes everyone's lives easier. And I think on days where the team is really working well, where I'm working well with pharmacy, or when I'm working well with nursing, or whoever it may be, my day is much more enjoyable and efficient than those days where, I'm sitting there trying to do everyone else's job, and vice versa. And I think that does get back to the ability to communicate effectively. And as we talk about dynamics, that communication, I think, is really, really important. I know when I was going through training, which was not so long ago, we did not learn interprofessional communication, how to communicate effectively with those others on the team in a way that builds team unity and dynamics and those sorts of things. I think we're seeing this a lot more in training, but this is something where, as we talk about how do we incorporate team-based care into continuing ed, those learning objectives around how to communicate effectively. What are the words? What do you say? How do you explain roles in a way that really breaks down barriers and builds teams together are really, really important. And I think that's for me something that we work on in my teams every day, is just communicating effectively with the teams around us.
Before we go to Michael, I want to ask you, Roy, one question. You talked a little bit about scope, okay? You just nibbled around it, but how does scope of practice affect team-based care, in your opinion?
Yeah, it's really important. This is such an important question too. I think the less we talk about scope, the more it hides in a black box and no one knows what's going on. And everyone is sort of dealing with scope in their own, this is my personal opinion though, but is dealing with scope in their own sort of individual silos. I actually think that if we sort of get this out there and understand roles and responsibilities around the patient, that it makes that conversation a lot easier. For the students, it's easy to do because there's not all of the politicalness of scope that's there. And I'll tell you, the MD students, they want to run in their lane and they want to manage the patient effectively. The nursing students, they want to practice in their lane and they want to do what they're able to do and practice at the level of their license and do that effectively with the team around them. The pharmacy students, the OT students, when you put that student group in a room, everyone is engaged in managing the patient effectively and recognizing what they should and should not do. And last thing I'll say is when you're working with a great intern, that intern knows what they know and knows what they don't know. And that is a defining characteristic of a great intern. And interns are willing to figure that out. I think in different professions, you see when you talk to people that there's a lot of that recognition. So some of this, I think, is just understanding and getting that communication out there. But that is a tough, a delicate subject.
We've struggled with that topic for years, as you probably know. And I think you're actually still on the hot seat because I think Tina wants to ask you another follow-up question. Tina?
Thank you. So as I was listening to the conversation, and, it of course made me think about how do you think about, so we know what is good for the patient and what would drive patient care and you talk about understanding between the roles, etc. But how about so we're promoting team-based care, but we're rewarding the individual. So there's a disconnect there, right? In a way. What are your thoughts around that? And how can an organization foster, or does your respective organization foster and promote that through, the structures and the incentives, et cetera, that you have in place?
So I'll let some others answer that as well. There'll be good answers to that. As you say that, one thing comes to mind. We just here at Wake had the distribution of our Hero Award this year. And I had no idea what the Hero Awards were going to be. I mean, this was a pretty heroic year for us all. And there were some pretty phenomenal people out there in every institution, in every practice, in every health system. And so I logged on to see kind of, well, what was it going to be? I think there was probably one or maybe two individual awards that were handed out amongst the 16 or 20 kind of hero awards. It was the stroke team, the ER team, the MICU team, and it was really incredible to see, hear from our, CEO coming down from the very top, recognition of the importance of team in being heroic and making big strides in tough situations. There's got to be some infrastructure change around that, and I think you're right. That needs to kind of sift all the way down. But that was neat. I think a really good example of how that team-based care and team model of care can be rewarded.
Okay. Michael, let's go to you next. And Danielle, you might want to remind Michael what the question is. Can you do that? She's not listening.
It's in the chat.
It's in. There she is. Uh-oh.
What are the team dynamics in each of your experiences?
Yeah, so I think that taking off of Dr. Strowd a little bit, that probably we like to throw a lot of terms around, right? We collaborate, because that's what team-based care really at the end of the day is all about. It's how do you collaborate with fierce respect for what everybody brings to the table. And I think that that when we do that and we do it well, it works well. And the only way it really works well is if everybody invests the time and the energy on the front end to be ready for when it actually happens. So I think that probably the place that I see it, because I'm always, and again, I'm not a clinical guy, right? So I don't get into this stuff. I don't spend my time in this stuff. But every now and then I just stick my head into the daily safety huddle, because I'm just fascinated by, number one, the number of people, and it's every walk of life in the entire institution. And they're all being honest. There's a level of trust in the room that is just incredible. And when it boils down to it, if there's something going on, that means something didn't go well. And rather than, conventionally, dare I say, 30 years ago, we might not have talked about what really did happen that caused that issue. But now we're all in with, okay, here's what we know happened. And you just have people just speaking up. Yep, well, here's what I know about that. And they figure it out. Well, there was a breakdown, and the breakdown was usually around communication. And I think Dr. Stroud's hit the nail on the head there. But in order to have that, the amount of energy, and people have to be given the time and the skill set, first of all, we can get back to that, but the time to really develop that level of fierce respect and trust for all the right reasons. And I'll take it back even a little step further. So the other place that I spend time with medical students isn't on the clinical wards, because again, that's not my stick, but it's before they get to the clinical wards, right? And to have those IPE discussions with preclinical students of all shapes and sizes and programs, that's a heavy lift. And we just started, we're really excited about it, but it's taken a lot for us to get this off the ground. When you're talking about preclinical, they're still, in the didactic, the lecture, the learning stage of their professional training. And we're doing it with the Wake Forest PA program. That's kind of the Wake Forest arm on it, with the entire, I call them the cast of characters of programs from Winston-Salem State University. So it's interprofessional and it's cross-institutional. My goodness, you wouldn't believe the challenges of how do we even find a date to put together the date for a kickoff because you've got, 6 or 7 different programs. You've got 2 institutions, different schedules, different expectations, different time frames and requirements for various things. So we've got all that together. And then we said, well, we need to really do something really cool and awesome. And Winston-Salem State was doing a bunch of stuff with their various professional students. Wake Forest was doing it with theirs. There was no connection of an EHR, right? So again, any institution that doesn't have a clinical setting, Winston-Salem State, they don't own a hospital, they don't own a clinic, they don't have an EHR that their students can tap into, carefully learn about. Well, luckily there are companies out there that have created these, and we've kind of contracted with one to help them put together some real dynamic EHR based IPE education before they get to the clinic, to learn how to use the right words, to not be offensive, whether you intended to or not. And I think that's kind of hopefully that's going to be a bit of a secret sauce, especially for those institutions that don't have every health professional being educated within those institutional walls in the non-clinical setting. So I think we're kind of seeing some of that come together now. And the really fun thing about it was everybody knew each other, like the Winston-Salem State program leaders and the Wake Forest folks. And everybody knew each other, and there was a healthy level of respect. But we had to work on that. We had to really kind of lay it out in very clear terms. Here's what we're bringing to the table. We even put it in a chart. And those of you that worked with the Future Clinical Leaders College, the chart I'm talking about. And it's a simple chart but it forces the conversation. And I think it takes time and energy to do that. But I think that's the kind of the secret sauce on how you get these projects moving and grooving.
Super. Thank you. And lastly, Danielle, I want to give you a chance to answer that question on team dynamics in your organization. Please, ma'am.
Yeah, I'm gonna maybe take a little bit of a different slant to this because I think the other 2 answers have been so good. I mean, when you asked the question, or Melanie asked the question in the chat, I mean, the first thing I wrote down was respect. You have to have an environment of respect. You have to have an understanding and appreciation for the other team members, and you have to go back and have security in your own role and security in being able to speak up and provide that role to the best of your ability. And if you work in that environment, works great. If you don't work in that environment, if the environment is all about I, and not we, then you're not going to get, you're not going to get the results that you want, obviously. And we can go back to any sports team metaphor that you want and be able to pull on a million different stories about that. But I will kind of advocate. We've talked about a lot of different disciplines. We talked about interdisciplinary collaboration, but a real life experience for me when I was a family practice doc was working with scribes, and my scribes were MAs, and they were my team. They were part of my team, just like my triage nurse was part of my team. They worked with me day in and day out. They were in the rooms. They learned from me. Their scope of knowledge increased because they were hearing about patient discussions and treatment plans and everything. And over the course of working, over time, their fund of knowledge grew, their relationships with my patients grew. And when my patients would call into the practice, if they got to speak to one of my MAs, they trusted them, they knew them, and their relationship was not just with me as their primary care doc, but it was with my team. And so a lot of times that expanded the relationship in the bandwidth, and the patient had relationships with more than just me as their primary care provider. There were times when they would bring things to me and say, "Hey, Dr. Mahaffey, did you mean to do X?" And I would say, "Yes, that's exactly what I meant to do." Or, "Oh, thanks for bringing that to my attention. No, you know what? You just caught something. Or would you like to do this?" So I respected them. It didn't matter, they were medical assistants, but they knew our patients, they knew me, they knew the environment, they had relationships, and they were so valuable to the patient care that we drove. So again, I would say that we can look at team-based care in so many different ways. every single person that is involved in patient care. And the medical assistants that I worked with, if you looked at their job satisfaction, they were providing within their scope what they could do. They couldn't give medical advice, they couldn't interpret, they were working under an appropriate scope, but they enjoyed their job more because they were working in a team-based fashion with me than, and so we did studies on what is their job engagement and job satisfaction. So I would say that is that is another way of looking at team-based care that we haven't talked about, but adding even scribes into the mix or that sort of thing, they're a member of the team too.
Super, thank you. Well, let me ask you
Franklin,
a quick follow-up. Do you think that team-based care, to be effective, must be physician-led?
Hey, Franklin, can I follow up on that last conversation just real quick?
Yep.
So, sorry, I don't mean to derail you on that. I know we're talking about this. I had just something come to mind. So, and I'm a big metaphor guy, right? So I'm going to tell you some crazy story, so I'm a glutton for punishment, right? So I decided, I walked up to coach basketball for my 5-year-old. And this is one of these great stories, right? So I show up for the first practice. There's not a coach. There's like me and a bunch of parents and no coach. And the guy walks up and says, "Who wants to be the coach?" All the other parents back up. And then there I am left in the middle. So anyway, so for the past 5 weeks, I've been coaching, 5-year-old basketball. And during COVID, so you can't do like anything you would normally do. You can't even do a huddle. And we spent the first bunch of practices and games, you can't huddle the team together at the beginning. You can't huddle the team together at the end. And practice just in games started off kind of weird and everyone left unfulfilled, without that. And so now we do a huddle. It's like a 6 feet away from everybody, no hands touching, and you're trying to get 5-year-olds to do this. Mind you, huddle. And I say that because I actually think an actionable step that everyone, even those in non-academic practices, can take away from this call is the importance of that huddle. And Michael, I go back to that patient safety huddle that you bring up. And when I was in the leadership college, we worked with an outpatient private practice group to set up a very short patient safety huddle in their private practice. And it completely changed the entire dynamic and culture of their practice. And so I think, that's a really important takeaway from this. It doesn't matter where you are, or who you're practicing with, or how big your shop is, academic, non-academic, community, or what your practice is. I think that's a very small step that you can do. The ability to acknowledge who is on the team and just know their name and give everyone a voice is unbelievably powerful. You need zero training to do that. I mean, it always helps to have a little bit of training, but that is a very simple step where you don't have to go back to medical school and through all these things that are now, a part of the curriculum, that I think really does allow a team to start to embrace that sort of team-based care, respect, trust, all those things that you were talking about.
I think that's a great analogy. Takes me back to my days of coaching my boys in Y basketball. I hope you're enjoying it. I want to stay with you, Dr. Strowd, and get in a couple more questions to everybody. We're getting close to time. Do you think that team-based care has decreased the stress and burnout level among care providers, physicians especially, and reduced medical errors?
Yeah, tough question. Because the obvious answer is, oh yes, everything's great. Every day is great.
Yep.
I love to come to work every day. You end at work, feeling great every day. And the reality is, that's just not the case. There's a lot of stress and burnout in what we do. And I think when we bring that stress and burnout to the team, the team, can dysfunction. And so the way I would answer that is, if we're not investing in the team in those small ways, I'm not talking about big culture changes, but a small huddle at the beginning, a small huddle at the end, those small steps, I think, to invest in the team allow you to get a lot of satisfaction out of your job. I do a bunch of different stuff, education, research, kind of all this stuff. Where I love to be the most is in the clinic working with my team. If you ask me the days that I leave where I found the most satisfaction, it's when I was able to work with that team to really see and show the change in care. And when you work with the team, that's when the care, I think, changes the most. And it's the medical treatment and the social driver and the patient education, that's when you really see all those things. So in the big term, I think it absolutely does, but I do think it takes that investment, very small investment in the team to make sure that is the case. And if you're not finding that, I think those small pieces of acknowledging it, checking in with your team, and doing those things can help to make sure that everyone is being fulfilled and it's helping with efficiency.
Super, thank you. Michael, I want to come to you next. A different question. A little bit of background. Power Hour started in the midst of COVID. And so we're, basically a year and some in, so where the question's going. How has COVID affected team-based care from your perspective?
Yeah, I think from the educational perspective, it's required an immediate about face on assumptions, right? So in the education world, that leads the team-based care, it was, pretty traditional. Everybody show up in the same room, and we know it's the least effective way to educate people, but let's just sit everybody in our neat rows and have some brilliant person stand and spew knowledge from the podium, and everybody get so excited and evaluate them, right? And what we've really been required to shift away from that. So what is it really? And things like the 10-minute TED Talk, the Pearl. I mean, the Pearl has kind of been that was years ago kind of a thing, but we still do that kind of stuff. But so we've gone from the sage on the stage, right, the brilliance spewing, to the guide on the side, the facilitator, the team base, the in their practice. And I think it's here to stay. I mean, will we ever get back to, enjoying our annual meetings at some nice location somewhere with social time and networking? Lord, I hope so, because I miss it. I miss it terribly. But I think it'll be fewer and far between than what it was. And I think it's really going to be more where you are, so it's the more the guide on the side. And I think the best example from our AHEC world is probably one of the most amazing things that I have seen happen in my 20 some years of being involved is our practice support coordinators. So these are clinical people who are brilliant and talented and experienced in the clinical setting, whether they're a nurse or a manager of some sort, whatever their role was. They're going out to, good old Doc Jones's office in the middle of Alexander County and saying, hey, I'm here to help you with your MIPS and your MAPS and all your stuff that you have to do these days, right? What do you want to work on? Because I'm here to help you. And sometimes it's, well, here, give me your hand. Let me put it on the keyboard. And it's not going to hurt you, right? But it's that so impactful that I have seen that group across the state of North Carolina put together some of the most amazing outcomes. So I think that's kind of how I would answer that, is that I think the educational process of the lecture-based, that everybody show up in the lecture hall and listen and clap lightly as you grab your box lunch on your way out. I think those days we need to bring those to a close. And I think we really need to start getting into the actual meat of the issue, is how do you help that practice out there deal with whatever it is? How do you tie quality improvement data, which we have more than enough to shake a stick at? How do we tie that to these things we call grand rounds, which are really educational interventions? They're not going to fix everything, but boy, they should get you off on the right foot.
Yeah, super. I've got time for one more question. Danielle, I want to come back to you in a little derivative on the question that I just posed to Michael about how COVID has affected your team-based care in your institution, and maybe perhaps how telehealth has been leveraged. Please.
Yeah. You had asked a question earlier, then we got sidetracked a little bit of it as to whether or not the physician had to be the leader of a team. And I'd say absolutely not.
Yeah.
Absolutely not. We do nurse-driven annual wellness visits where the nurse is doing that and then just sharing that with the physician or the APC. We have lots of different models where we have various leaders. So I would say whoever is, that the person in the leader needs to be the primary source for the patient, and whoever that is should be the leader. It doesn't necessarily have to be the provider by any means. So I wanted to make sure I answered that question because I think it's important. I think from my perspective as a physician, I look at some of the things that I'm involved in and with direct patient care, but there are many, many examples of where we have other team members who are leading that team.
Thank you so much. It's been again, wonderful session this hour. We so enjoyed having these guests. Thank you so much to Dr. Lischke, to Dr. Strowd, to Dr. Mahaffey, who we lost here at the very end. But as you could hear, rich, engaging, and very important conversation to have and to keep having. So this wraps up this week's Power Hour. Please join us again in 2 weeks when we will be back. We will make sure to announce the next theme and who's going to be with us that time. Again, thank you so much for those of you who listened in today. Thank you above all to our guests, and stay dry, stay safe, and have a wonderful weekend. And above all, stay safe.